And Soundarya, can you start?
Okay, okay.
Dr. Soundarya, can you share your screen? And Dr. Soundarya is a young cataract cornea and refractive surgeon from the Eye Foundation group of hospitals. And I'm sure her talk is going to reflect on the amount of knowledge which is hidden in this young brain. So her topic is, how do I plan my cross-linking protocols when combined with the refractive surgery? On to you, Soundarya.
Good evening to all the respected panelists. Thank you so much, Chitra ma'am, for the introduction and for this opportunity. So I'm going to be talking about combining laser vision correction with cross-linking. So as we all know, laser vision correction has shown excellent immediate post-operative results. However, when it comes to long-term visual outcomes, especially when we're correcting higher refractive errors, the results have been less satisfactory. The main reason being the need for retreatment and the cause being regression. So the need for retreatment in high myopia goes up as high as 30%, and the incidence of ectasia is about 0.03 to 0.6%. So as we do a tissue removal and a flap creation, it ends up causing a biomechanical instability. So combining cross-linking is theoretically thought to compensate for this biomechanical weakening caused by the laser LASIK. So this is based on the fact that cross-linking for keratoconus has shown to cause an improvement in vision as well as the corneal curvature, and also both these factors are found to remain stable even after 6 years in cases of keratoconus. So now the so-called extra procedures can be combined with either PRK, LASIK or SMILE. The primary goal of combining cross-linking would be to prevent post-LASIK ectasia, and the other goals would be to improve long-term refractive stability and also to reduce the rate of regression, especially in cases of hyperopes and high myopes. Currently, there are no consensus or recommendations as to what is the exact indication for adding a cross-linking. However, they have told that patients with certain risk factors for iatrogenic ectasia and regression could be good candidates. So one would be young age, high myopia or hyperopia, as I've already told, patients with thinner corneas, patients with borderline residual bed thickness, patients with moderately high ectasia risk score, and patients with borderline topography which is not amounting to the diagnosis of keratoconus, for example, an IS asymmetry or a borderline bad display value. And other contributing history is also important, like chronic allergy, eye rubbing, or family history of keratoconus. Just a few examples. So at our center, we tend to mostly combine extra procedures with PRK. So cases like this where there is a thinner cornea with as we can see, it's around 460, 470 thickness with a moderate amount of myopia, they would be good candidates. Or here with a normal refractive map, as we can see, but with borderline changes in the pad display again. Or in cases with borderline thickness around 480 with a higher amount of refractive error that we need to correct, again we could add cross-linking, provided that the residual stromal bed and the PTA are within normal limits. So this is a case of just an inferior steepening with everything else looking absolutely normal with a low refractive error to be corrected. So in these kind of cases, again, we do go ahead and add cross-linking, and in these kind of cases, we have done full fluence cross-linking, especially like a 30 milliwatt for a 3-minute protocol can be done. But what needs to be remembered is whenever we see just an isolated inferior steepening, it's always a good idea to go ahead and repeat the topography to see whether the steepening goes away. In most of the cases it does. And this is a patient where the topography looks fairly normal with a good thickness and a minimal amount of correction that has to be done. However, in the cornus, the TBI is found to be abnormal. So here again it is debatable whether in such cases the extra procedure is absolutely needed or not. Procedure-wise, here we're going to be doing a shorter riboflavin soak time with a lower total UVA energy used when compared to what we do for keratoconus. And in the LASIK extra, that is flap-based procedures, we're going to initially finish the laser procedure, then add riboflavin to the stromal bed, and then once the riboflavin is instilled, the bed is going to be irrigated and the flap is going to be repositioned, and then the UVA irradiation is going to be done. In PRK extra cases,
just 1 minute, Soundarya. Please all mute yourself because there's a continuous talk from the background. Okay, Soundarya, carry on.
So in the PRK extra procedures, the only additional step that we're going to be doing is adding a mitomycin C, a 0.02% mitomycin C, in order to reduce the amount of phase. And in SMILE extra procedures, the riboflavin is usually instilled into the cap interface, and then it is washed, and then the UVA radiation is applied. Now there are multiple protocols that have been suggested, but there is no standard as of today. So these are the reference articles for the protocols. So the riboflavin used here is going to be of a higher concentration, where we use a 0.1 in a normal keratoconich eye. Here we're going to be using a 0.22 to 0.25% riboflavin. And on the various studies, they've used it anywhere between 45 to 90 seconds and even up to 120 seconds in certain studies. And the UVA radiation is usually used at 30 milliwatts for again 45 to 90 seconds with a total energy of 1.4 or a 2.7 joules. So at our center, we use 90 seconds soaking with a 30 milliwatt for 90 seconds at the half fluence rate. So Ohana et al. Reported a study with PRK Extra where they used full fluence accelerated protocol with a 9 milliwatts for 10 minutes. But in that study, they reported more haze. So the riboflavin, because it is used in the stromal bed, it obviates the need for deepithelialization, which is one of the major drawbacks of cross-linking. And since the flap does not contribute to the biomechanical stability, the cross-linking of the flap is not necessary, and it could also be detrimental because it can lead to subsequent shrinkage. And it is also important to avoid riboflavin contact with the flap, and some authors have told that the flap can be folded onto itself in order to prevent the spilled over riboflavin from touching the inner surface of the flap. When talking about the refractive outcomes, there have been various studies which have compared LASIK Extra with normal LASIK in high myopes, and they've shown that the predictability and visual acuity are better. So one study by Tan et al. Showed at 3 months, and the Canalopolis studies followed up the patients up till 1 year and 2 years, and they showed that the uncorrected visual acuity was found to be better in the Extra group. And when you're talking about stability, majority of the studies have shown greater stability of refraction in the LASIK Extra groups, and they have shown comparative or better results in refractive and keratometric stability in Extra groups. And observational study up till 2 years of the Canalopolis et al. Study also showed the similar result. And they have also told that addition of CXL is going to have an influence on the epithelial remodeling as well. So in higher myopia, the study by Canalopolis et al. Showed that there's a significantly lower increase in the mid-peripheral thickness, so which is the major reason for the regression in such case. In hyperopic correction, again, the contralateral eye study which was conducted showed the lower mean regression in cases of combining with Extra procedures. There was a study with a longer follow-up, a 4.5-year follow-up. However, the sample size was too small. When talking about safety, all the studies have shown that the endothelial cell count is stable and there's no visually significant haze. However, Saylor et al. Reported higher incidence of DLK and a delayed visual recovery in the LASIK Extra group. And also in PRK Extra, there may be a slight increase in incidence of haze, but not visually significant, which usually resolves in 6 months. And this can be reduced by addition of mitomycin C. So it is, as we know, it is a challenge to demonstrate a statistically significant reduction in ectasia risk because of how rare the complication is and how the large amount of sample size that is going to be required. So there was one report in 2017, the first case of post-LASIK ectasia in a patient who underwent LASIK Extra. But what needs to be remembered here is this patient had undergone a microkeratome LASIK in an FFKCI, which is ideally not to be done. Drawbacks of combining cross-linking: one is the increased procedure time, but not by much, and the increased risk of infection because of the use of riboflavin, a possible increase in corneal haze. And as we all know, cross-linking after creating a flap, so does it actually add to the biomechanical strength, is again questionable. And some authors have told that the flap may be more difficult to relift once an Extra procedure has been done in case of necessitating an enhancement. And the question of whether a specific normogram is required for refractive correction has come across, but most of the authors have agreed that it is not required because when they're going to be using the accelerated protocols, the necessity for the change in the refractive outcome is not going to be much. So the most important and most practical challenge in adding the Extra procedures is going to be the cost burden that's going to be there for the patient. So to conclude, as we all know, post-LASIK ectasia is a very big challenge to treat. So if a prophylactic cross-linking can prevent this high risk in high-risk eyes, then Extra may be worthwhile. So at present, we don't have adequate data. And as of today, what we know from the literature review is that adding a cross-linking is a safe option. But is it effective? So we are left with more unanswered questions like, is it effective in preventing regression and ectasia? What are the exact indications to add this procedure? And we definitely require more standardized irradiation protocols when adding the Extra procedures. Thank you.
Thank you very much, Soundarya. You threw a lot of light, but I guess in the expert panel, there are fewer of us who are doing CXL Extra, although I am convinced. So I think I'll take a question with Shreyas, and if Namrata or Mahipal, anybody wants to add, you could. So we do believe, we are convinced that it has a role to play in some of these very borderline suspicious topographies, and the aggression with which we have moved on to phakic IOLs, the requirement of an extra procedure has become far, far less. But having said that, believing there is some kind of a stromal remodeling which is more controlled because of the CXL add-on, would you try to like doing a little higher refractive error in a thinner cornea where you expect regression? Would you feel more justified in doing a PRK extra on this eye? Shreyas, I'm going to ask you that.
I think, Soundarya has beautifully summarized the entire talk. I would say at this time point, if there is a concern regarding regression, definitely we would go in only for a phakic IOL. Only if the rare case that the anterior chamber depth does not allow a phakic IOL are we going to consider PRK extra. Like Soundarya said, there is enough literature now to say that the extra procedure by itself definitely does not do any harm. How much benefit it gives is still very questionable. The very flash cross-linking that we have is whether it is sufficient to prevent ectasia altogether is less likely, and that's why we still have to follow the same stringent protocols that we follow for a regular PRK, even for PRK extra as well. So it's just including those slightly borderline corneas with slightly lower pachymetry, which normally we even hesitate to do PRK, but for a low myopia, these are the few cases where possibly an extra procedure is being done.